This is the second in our series of webinars hosted jointly by the Centre for Public Engagement of Kingston University and St George's University of London, and also with the NIHR Research Collaboration, Applied Research Collaboration, South London, the PPI research theme. It gives me a great pleasure today to introduce Jim Elliott, who is going to be from the Health Research Authority, who is going to be talking about the lessons learned from PPI engagement during COVID. I would now like to formally introduce Jim Elliott. Jim leads the work of the Health Research Authority on the involvement of patients and public in health and social care research. And much of this work focuses on NHS research ethics committees and external influencing factors related to areas of PPI ethics. And as part of the Health Research Authority's response to COVID-19 pandemic, Jim and his colleague, Lenny Sevi, were asked to support public involvement in research. The usual approaches for involvement of patients and public were not working for COVID-19 research. So now Jim will describe in this presentation the issues they found and what was done to address those issues. So Jim, over to you.
Good morning, everybody. Very pleased that you can join us today. So as Mary said, I'm going to talk you through some work that we did over the past year or 15 months or so. From some of the names I saw pop up when you were joining, I see there are a few familiar names, and some of you will be aware of some of this, but it's not all the same as we presented in January. So the background to setting up what we did, what we called the matching service, how it was set up and run, and some of what we learned from it was what we presented in January. But I'll then go on to talk about more about how we're trying to take forward some of that learning and to make the involvement of patients and the public in health and social care usual practice across the UK in all sectors. Whilst what I'm presenting is from a Health Research Authority perspective and work that we led, everything that I'm going to talk about was, and all the successes of that, was absolutely the result of a collaborative effort right across the public involvement community in the UK in all sectors. And those of you who are on the call who are involved, thank you very much for the part you played in it. And anybody who will perhaps be involved in the future, thank you in advance. As you're probably all aware, at the beginning of last year, the research community responded in a phenomenal way to the COVID-19 pandemic, and studies to find out more about the disease, how to treat it, and of course to develop vaccines were set up in incredibly short timescales, far faster than anything had ever been seen before. And you may well have heard in the news about the recovery trial, which has been using a whole series of existing treatments to see if they work for COVID. And that was completely unprecedented, from the original idea of will some of these medicines work in COVID, to actually the first patient being recruited was just 9 days. Nothing like that has ever happened before. That's raised some concerns about, is everything being done too quickly and is it to the same quality? But actually it is. When we're hit with a disaster, with a really bad situation, people and organisations change the way they work and throw more people, more money at it to do things quickly. So as far as I'm concerned, and from what I've seen, the quality has been very high in everything that's been done. It's just the timescale that's changed. The Health Research Authority responded in its own way by changing its approval process to be much, much faster than normal. So whereas the sort of typical timeline in peacetime, as we might say, is up to around 60 days, we got that down to 5 days. And for certain studies, if we got notification in advance, and that's an important point for later, like we did with the recovery, within 5 days, and in some cases, like the recovery trial, the ethics committee met on the day the application was submitted and gave their approval. Things can be done very, very quickly that way. As I said, the quality was remained high, and for the Health Research Authority's ethical review process and research governance requirements, we kept the same high standards. I said in the introduction, we have good connections with public involvement contributors and with people working in public involvement across the UK. And we very soon, sort of March time last year, people saying actually there seems to be a drop-off in public involvement. People are there wanting to help and nobody's asking us what's going on. We're also aware that some groups had set up, some organisations had set up rapid response groups specifically to help with COVID-19 research, but actually there weren't very many requests. In response to that, what we did was, particularly my colleague Lenny, looked at what applicants for COVID-19 research applications were saying to us in their applications. And as you're probably all aware, there's a question on public involvement in the integrated research application form that's used for Research Ethics Committee approval. And we'd been looking at that data over the last few years, and we'd seen a normal value of 4 in 5 or 80% for all studies before the pandemic, which doesn't necessarily mean it's high quality involvement. It's the applicants saying we involve the public in these different ways, but doesn't actually assess the quality. So it is a self-assessed value, but it's still an important one. And that dropped to just to barely 1 in 5. The researchers said in their applications that all the compressed timelines, working quickly, and logistical challenges, which they often didn't go into, were the main reasons they decided not to work with patients and the public to develop their studies, i.e. they're making a lot of assumptions about what could be done. We got some sort of confirmation of what was going on in a workshop, stakeholder workshop we held in late April. And out of that came a call for action, a call for cross-system collaboration and communication, some leadership nationally, and to try to sort of bridge what appeared to be a gap between researchers and existing public involvement infrastructure, so public involvement groups and networks and individuals. So that evolved into what we call the UK COVID-19 Public Involvement Matching Service. So because we knew that public involvement groups had adapted rapidly to remote working in the same way the rest of the research system was, and that we knew from what anecdotally from people had told us, they were really keen to help make the COVID-19 research as best as possible. We thought there was a really good opportunity there. So we set up what we call the matching service partners. So we used our networks of public involvement managers and coordinators of involvement groups and networks across the UK in the public sector, so NHS and National Institute for Health Research organisations, charities, and working with our colleagues in the health departments in Wales, Scotland, Northern Ireland, the so-called devolved administrations, to identify groups and networks who had an interest in helping with COVID-19 research. So this wouldn't be everyone, it would be those that had a specific interest in COVID research. And the idea was to bring those together as a sort of network of networks, as it were, which represented around 8,000 different members across the UK, to be a resource to help researchers who wanted to involve patients and the public. And specifically, this was about involving people. This was about researchers who didn't already have access to a public involvement group or network, or to people like the NIHR Research Design Services that could help to facilitate that. So we got some applications which came to us through the HRA's fast track approvals process. So when applicants contacted the HRA to say, we're rapidly developing a COVID study, we're going to submit it to you in 2 weeks' time or whatever, we would, my colleagues in the approvals team would ask, and have you involved patients and the public? And if they said, yes, it's fine, then we'd say no more. And if they said no, they would then ask them, have you got anyone who can help you do that? As in, where are you working, whatever. If they hadn't got anyone who could help them, then they were sent through to Lenny and myself, and 2 colleagues working from charities who are helping to make the service work. And then we took that forward. So this map just gives an idea of where the various groups and networks are based, just about covering the UK. They were, as I said, they were in charities, universities, NHS organisations, and covered a wide range of interests. The information about the public involvement groups and networks was put on a database, a simple, very, very simple database on something called the Engagement Practitioners Network, which is hosted on the Future NHS Collaboration Platform, which is something NHS England has set up. The overall platform is to support NHS or health and social care staff, not just NHS, to learn, share and support each other. And the Engagement Practitioners Network, for which you can read Involvement Practitioners Network, because engagement tends to be the term used in services, is there for people who work in public involvement, who involve patients, carers, service users and the public in research, to support each other, to learn together. So that was an ideal place in which to put that. And I'll come back to that again later, because that's going to be part of the future as we move forward. Very briefly, for each of the groups and networks you put up there and on the database, with a contact, one single contact person for each group or network, how many people, where they were based roughly, areas of interest and expertise, age range if they knew, and ethnicity if they knew. And those simple demographic bits of information I'll talk about a little bit more later. And then the researchers, we wanted a very simple summary of what they were doing, what sort of involvement they thought they needed, how many people they wanted to work with, what was the relevant experiential knowledge that was needed, and what their timeline was, however long or short that might have been. And then we used that information to go out to the database, which was contacts for each of the networks. And then we asked them, do you think your group or network might be interested in helping in this study? And if they thought they were, they would contact the researchers directly to say, we've got a group or network who we think can help you. Would you like us to contact our members? And if they said yes, then a sort of match was done, and the information then went out to the members of the group or network. The key thing there is that members of public contributors, members of the groups and networks, were being contacted by the people they were familiar with. So they weren't being contacted by researchers they didn't know. And that was quite important in terms of, we felt, in terms of continuity. In terms of the overall activity, it wasn't much, I suppose you could say, in terms of the overall number of applications. So between May and December, there were 700 applications for the fast track service. And 22 teams applied and were supported by 13 different groups and networks across the matching service partners. The input was mostly, almost entirely, late into an already shortened timescale. We had some where we were trying to do something in less than a week. The better planned ones gave us up to 6 weeks. But remembering that this is in a situation where, instead of research studies taking 6 to 9 months or more to set up, they were being set up in that many weeks. So 6 weeks in maybe a 9-week setup is moderately early, but still not early enough. Mostly they covered very typical kinds of things, the importance and relevance of the question, acceptability of the methods, and particularly a focus on participant-facing information. So you could say actually easy stuff and maybe things that wouldn't change radically the way the research was going to be done. But we had a view there that, well, better something and some involvement than none at all. Interestingly, most of those 22 research teams were new to working with patients and the public. We saw quite a few light bulb moments. Oh, working with patients in the public, that's a really good idea. We should have done that before. Some of the teams intended to continue to work into the future. And one of the reasons we asked for geographical location of groups was, if possible, to link researchers to people who would be close to them for the future. One of the main parts of the service we set up was that specific matching service, but it was also, as requested in the workshop we had in April, it was a call for widespread communication across the research system. And there was a very strong call out from National Institute for Health Research, from the Association of Medical Research Charities, the Association of the British Pharmaceutical Industry, Academy of Medical Sciences, and others to flag the importance of continuing to involve patients in the public, with a really key statement that public involvement is important, it's expected, and it's possible regardless of the circumstances. And that was a very important overarching piece of work that we did, again, in collaboration with many people across the research system. And the mediated matching service, the dating service, as some people referred to it, was there really only for some applications. And the graph you can see there shows that in 2019, for all applications, we were seeing 4 in 5 applicants saying they were involving the public. That fell to just over 20%, as I said earlier, in March. But actually, there was a very strong recovery in terms of what was reported in applications for the COVID service to around the same, in fact, slightly higher than we were seeing last in 2019 for all studies. So that takes us on to what did we learn? So we did an evaluation, looked at the data we had. Lenny interviewed a great number of people who were involved in the service in different ways, both applicants who used the service, public involvement managers and coordinators who helped facilitate the service, and public contributors who were part of it. The specific matching service itself, the dating service, was felt to meet a need and that complemented existing support. And I really want to, to emphasise that where there were public involvement services, public involvement managers, coordinators, advisors, close to the researchers, that was what provided what was needed. We were only supporting those who didn't have access to that. And where we provided that, it was very enthusiastically received. But we have to point out that it was based on fantastic goodwill. And so running what we did in the longer term with just Lenny and myself and the Health Research Authority and our 2 charity colleagues wouldn't be sustainable in the longer term. So if we were going to carry on, we need a different solution. It was also clear that we would need for anything in the future, and as with what we ran, we'd need some very clear standards for what we were offering and what could be offered into the future. We learned actually a lot about public involvement in the pandemic specifically, and what was really important was, although we had that one-to-one matching service, the clear high-level messaging about the importance of public involvement, that it's important, expected and possible regardless of circumstances, and there's help available. That, we feel, was the key thing that changed researcher behaviour, as we saw in that graph I showed you earlier. So we, again, anecdotally, from a number of people who support public involvement, we heard that they got more people contacting them to be involved in their COVID studies than in the early days of COVID. And that was very important. And the collaboration was, I can't overemphasize how important that was. Whilst Lenny and myself sort of provided the kind of the overarching coordination and leadership, perhaps, we couldn't have done any of this without the collaboration of so many people across the system. And it emphasises the need for that at all times in general. So in terms of what we call business as usual, what did we learn about public involvement from the experience in COVID? Well, the key thing is that that kind of collapse of researchers approaching public contributors directly or through groups and networks illustrated for us that it isn't integrated in research in normal practice, as I think we would hope it would be. And having had a career in sort of research management and public involvement that spanned the entire period of sort of the organised public involvement in health and social care research, from when Professor Sir Michael Peckham set up the Consumers in NHS Research Standing Group in 1993. It's been a long time, and you would have hoped that it would be more integrated than it is. But actually, I think what we found is that it wasn't. And we identified 4 sort of broad areas that we thought were issues and that potentially could be addressed. The communication gap, and what we meant here is there's a lack of clear and consistent high-level messaging about the nature, value, feasibility and importance of public involvement. And this is not to say there isn't any of that, because there is, and there are silos of it everywhere, but it's the consistency for all research, regardless of where people are. Similarly, an information gap, so this lack of universal shared information. Again, lots of good information, but it's not there universally, and it's not there for everyone. Particular gaps here for communication information with commercial research, which won't surprise anybody, I'm sure. Also, gaps in collaboration and leadership. So again, lots of good work going on in public sector, within National Institute for Health Research and the NHS, within charities, but there's a lack of resources and cross-system working needed to kind of create a wider culture. Researchers are perhaps aware that if they apply for funding from National Institute for Health Research, they've, as some of them say, got to do involvement, which is not really the right approach. But if they apply to someone else, they might not be given that same expectation. And that's mirrored in a kind of leadership gap as well, as a lack of clear cross-sector direction for public involvement in all health and social care research. So having identified those gaps, well, what can we do about that? There are three things that we felt are kind of pulled together really to take forward. So having addressing those communication and leadership gaps that I talked about, having a UK-wide all-sector commitment to patient public involvement being normal business is an obvious thing to try to achieve, because our small experiment, as it were, with COVID-19 showed that grabbed the attention of the research community involved and changed practice. Building on the collaboration that I talked about earlier, so supporting and enabling the network of public involvement practitioners, as you might call us, those of us who facilitate, support, enable the involvement of patients and the public in research across the UK, and building on what was done on the Future NHS Collaboration Platform, which again I'm going to talk about a little bit more again in a moment, to address those collaboration and information gaps. And then looking into that one-on-one matching service, is there an ongoing need? Are there people who can't access existing services, or can the existing system cope? Could we use the collaboration and information response to make better connections with existing services to support patient and public involvement in individual organisations through services like the NIHR's research design services and others. So those are the three sort of broad areas that we're seeking to address. At this point, it's worth just pointing out that if you look at the study setup pathway, as you might call it, so what happens to take an idea for a piece of research through to actually setting a study up, and look at the different organisations that are part of that. Research sponsors are generally the organisations in which researchers work, so they could be NHS organisations, they could be universities, or for a company, it's the company itself or a clinical research organisation, are involved all the way through, and they clearly must have an important role to play in helping to support public involvement. Research funders come in a little bit later in the day. Some of them are perhaps a bit earlier when they help to shape research ideas, but for a specific study, they're there from the point of giving out funding once it's been applied to, and then all the way through. And the Health Research Authority, its role actually is very late in the day. And it's worth pointing that out just simply because there's a potential limitation in our ability to influence unless we work very closely with research funders and research sponsors and the wider community, which is what we tried to do for COVID. And I think it's just worth me pointing that out because an expectation has now arisen that the Health Research Authority will carry on doing what it's doing. And I'm very glad for the support I've had from my colleagues and our senior team to do that. But it's in a sense going a little bit beyond our remit, but we're very happy to do that and we'll continue to do so. To take things forward, I'll come back to collaboration again. We have to keep collaborating and we have to get the message out very clearly about the importance of public involvement, the important, expected and possible, whatever the circumstance. But the key things here is that, as I mentioned earlier, I've been around since the start of what became Involve and then now the NIHR Centre for Engagement Dissemination, so a long time now. But it feels very much to me that in order to make public involvement usual practice for all research, the stars very much feel like they're aligned. Lots of things have happened in the wake of a very bad thing in the COVID pandemic. A lot of good has come out of that in many respects. and particularly for patient and public involvement. So there are 4 key areas here where we're going to try to build on this and take forward that learning from the COVID-19 matching service, and our realization that if you get the message really clear and it goes down through the system, the research community takes notice and their behaviour will change. So you hopefully will have heard of the Recovery, Resilience and Growth Agenda, the published Future of UK Clinical Research Agenda and Strategy. And I'll talk a little bit more about that in a second. There's a 5 Nations Public Involvement Group, which has evolved out of the UK Standards of Public Involvement Partnership. And this is going to take an important sort of collaborative role across the UK. 5 nations, because the Republic of Ireland are joining us in that, which is great news. There's the National Engagement, the Engagement Practitioners Network I mentioned earlier on the Future NHS Collaboration Platform. We must make better use and more use of that. And all of the organisations who help make the matching service work in itself. So NIHR, NHS, university, charity staff and services supporting patient and public involvement in research. That community is absolutely vital to make this happen. So I mentioned the Saving and Improving Lives agenda, which was published, strategy, which was published in March, which hopefully you will have been aware of. This has full ministerial backing from Lord Bethell, and that's important because there are five main areas, one of which is called patient-centred research, and within that, within the vision to make research open to everyone, to make participation in research as easy as possible, is the statement I've highlighted about patient service users must be involved routinely in the design of clinical research to ensure outcomes match their needs and studies are designed with real participants and the realities of their daily lives in mind. That's in there with ministerial backing being very important. Hopefully that will make the whole research community take notice. There are 7 areas of action in there, one of which, the last of which, strengthening public patient service user involvement in research. You know, again, to have something as clear as this to support what we're doing is really important, and we absolutely have to make the most of this to try to make patient and public involvement normal practice, normal service everywhere we go. I mentioned now several times the Engagement Practitioners Network. So the Future NHS Collaboration Platform was set up by NHS England and NHS Improvement in Innovation a few years ago now. That overarching platform is supporting NHS staff and other health and social care staff to basically to work with each other, learn from each other, and support each other. On that is something called the National Public Engagement Practitioners Network. And as I said earlier, public engagement tends to be the term that's used for working in partnership with people and communities, which is the phrase they and we now like to use in health and social care services, but this also covers research. There are currently just over 900 members, individual members of this Engagement Practitioners Network. The matching service partner database, which I talked about earlier, and which I showed you the map of, is hosted on this space. And this is there for effectively us as professionals who work to help public involvement work and function, and is open to anybody across the UK. They don't have to be NHS, doesn't have to be public sector. It is open to charities and even to industry as well, and to the academic sector. If anybody on this call feels that they would benefit from this and want to join it, you can search Future NHS Collaboration Platform and click on a registration link there, or you could email Lenny and myself at the Health Research Authority, and the email address will come up at the end, and ask us to invite you to join the space, and we'd very happily do that. I'd strongly recommend doing that, even if what you do on that isn't to put a public involvement group or network up on the space, but equally just to connect with other people with like minds. And for me, one of the important things here is the opportunity for people working on public involvement in research to learn from people doing that in services and vice versa. It's very much the same things we do, just the context is slightly different, but we do the same sorts of things. Really just to recap, show you the graph again, the recovery we saw for COVID-19 research, so in 700 studies, as it were, can be mirrored elsewhere. With collaboration and coordination across the research system, the involvement of patients and the public in health research can be made as business as usual. Within the pandemic, we made it business as unusual, you might say, but we can do this. And that message about involvement being important, expected and possible in all health and social care research and in all circumstances, regardless, is absolutely vital. And the vision for the work we want to do is that any researcher in any field with funding from any source will get the same message about the importance of public involvement and the availability of people who can help them find the right people to involve with the right, the most helpful experiential knowledge and help them to do it well. We need to keep collaborating as we have done, and a big thank you to all of you who have helped so far and will continue to help. Open to questions now, but I'll put the last slide up, which has got in particular got our email address on it, public.involvement@hra.nhs.uk. So if specifically you want to join the Engagement Practitioners Network, feel free to email Lenny and myself at that email address. Or if there are other questions that come to mind after this session's finished, again, feel free to contact us. There's links there to the report that we launched in January about this, which gives a lot more detail than I've talked about the service itself. And also for anybody who is involved in some way in submitting an application for Research Ethics Committee approval, there's what Lenny's called a cheat sheet there on how to write about your involvement to make it really useful and helpful to the Ethics Committee to help them know that actually you've brought relevant experiential knowledge into your application. And I'd strongly encourage you to look at that and to use that. It's currently in a section about a new fast track general approval service, but it applies to any application for ethics review. So finally, thank you for listening and very interested to hear your questions.
Jim, can I just say thank you very much for that, because that was really amazing. And to think of how much work that you actually achieved in such a very, very short time. And as you pointed out, despite the terrible time that we've been through with the pandemic, that something good has come out of it in terms of patient and public involvement. So hopefully that will now continue, and the resources that you have highlighted will make life easier, I think, in many ways for researchers. So now I would like to hand over to my colleague Duncan, who will look at what's in the chat. And then Duncan, perhaps at the end, if you could say something about our next webinar. So at this point, I will say thank you all very much for everyone who has joined today, and particularly to yourself, Jim. Thank you very much.
There was a question, a mini sort of discussion about membership or who can join the NHS collaboration platform, which I think, while I was typing, I think you've addressed, because I think I heard you invite people to email you or Lenny. So the specific question was, can a public contributor join that platform?
Yeah, I mean, a public contributor can join the platform. The platform is there specifically to support people whose professional role is in working in partnership with people and communities. There are some public contributors on the network. It's not there to support, I mean, I'm a public contributor outside my HRA role, and it's not there to support us as public contributors. But if, as a public contributor, you're working with somebody who runs or supports a network, and you want to, you want information that's going to help them do that, then by all means. But the space is not exclusively so, but it is principally for helping people do their work better, involve people better, be more inclusive, get more diverse people involved. The idea isn't that it's a network for public contributors to be on specifically, but there's no reason not to, if you feel you can make a contribution to it and learn useful stuff to help you do what you do as a public contributor.
Thanks, Jim. Francesco Palmer's got a raised hand. I think he's been posting questions as well. So Francesco, do come off mute and please.
Okay, thank you. Thank you for that, Jim Duncan. I guess the question to be asked, because the legislation is still in place, is that we've still got the control of patient information legislation as a result of COVID. Now, I ask this because speaking to a couple of research fellows at one of the academic universities, putting in an application to the Research Medical Council, they seemed a little bit coy to give enough information. And when challenged about involving patient-public carers at a pre-formative stage of generating the question, they informed me the funding that they're applying for from the Medical Research Council doesn't require any patient-public involvement. And I asked the question, well, I'm not too sure what the REC might feel about that. So I just wondering whether or not you've got some nice arrangement with the Medical Research Council where a favourable opinion may well be given. And one thing they didn't say at the time, and I pulled it out of them because we were talking about patients that were in induced coma, sedated, and they would enroll them within 3 days of coming into ICU. And having been in that situation myself, I challenged, once the person has regained consciousness, will you go back and get valid informed consent because you got it from the carer? And it seems that, they're not doing things as I would expect under normal circumstances. So I just wondered, if such an application came in front of you, would you require, once the patient that's been enrolled by default by the carer or family, that they should be spoken to once they've regained capacity, and then they can make a determination as to whether or not they want to be enrolled, given that they weren't in a position to begin with? That's the question. Yeah.
Well, I'm not going to go into specific ethical issues around consent, because that's actually for the Research Ethics Committee to do, even though I've got some ideas myself. But around the point you're making about the Medical Research Council not expecting the involvement of patients and the public in studies, we're aware of that. We are working to support and encourage them to do so. They do in some respects, but a lot of what they do as an organisation, they feel that, well, they don't have a particularly strong drive to do that because of their responsibilities are mostly on the basic science side. But involving patients and the public in basic science is just as important as it is in clinical research. So the national initiative that we are helping to take forward will expect all funders to have a strong view and encourage and support the involvement of patients and the public. So, it's not ideal what you're saying, but actually an ethics committee seeing an application, again, we're working with our committees to support them to use the information, the evidence, as it were, from the lived experience of patients and carers that supports the application to help them decide whether it's ethical. In a situation like you've been talking about, Francesco, they might well ask some very hard questions of the applicants about, well, how do you know this is going to be acceptable? And then you would go into all the further points you raised, which I'm not going to go into because they're not in my sphere of influence or understanding.
At least it's not put to one side, and the HRA are looking at it. Okay, that's great, Jim. Thank you. Okay.
Thanks, Francesco and Jim. Jim, there was a question from a colleague at the University of Edinburgh, and it's something that I noticed when you put up the map of the groups that are on the platform. Any thoughts of why the groups are so sparse, or perhaps non-existent even in Scotland?
No, well, it was, we used our networks to ask people, ask public involvement managers and coordinators of groups and networks if they had an interest, and we got the response which the graph, which the map shows you. It was disappointing there weren't any from Scotland, but again, there were some charities who covered Scotland who were in the matching service partners. It was, we couldn't really control it. in growing that network, we absolutely would want to have far wider and more diverse representation and cover Scotland more widely. It's just kind of happenstance. We asked, people responded, and not everybody responded from everywhere. But it's, you know, it's something we noted ourselves and would have liked to have seen better coverage.
But presumably still the opportunity for people to do so.
Yeah, absolutely so, yeah.
There is a couple of questions which sort of are focusing on the funding issues of patient and public involvement and engagement, which probably quite nicely builds on the first webinar that we held with our NIHR colleague Sylvia Bortoli, when she updated us with the guidance, the new NIHR payment guidance for PPI. Are you able to say anything, probably controlled by the actual member groups, wasn't it? But are you able to say anything about how public contributors or the groups were funded during the matching service?
Really good question. I mean, one of the detailed questions we asked each of the research teams that came to the service was, were they going to offer payment for time? I mean, they were told they had to cover any expenses, but were they going to offer a payment for time to the people they involved, with a very strong, you are going to, aren't you, kind of encouragement. Most of them did, but a few didn't. And that was probably, as much as anything, because of the fact, as I said in the presentation, most of them were new to involvement and hadn't even thought of that at the stage when they were, if they were applying for external funding, they hadn't even thought of that, and maybe the funder didn't suggest it. Those who came from industry took the point that they should, and it was a respectful thing to do, and they found the money. But there is a real issue there, that there isn't money available universally. So part of the messaging about involvement and the importance of it and the way to do it well will be about, wherever possible, making money available to pay people to recognize and reward their contribution. The issue around the tax status for public involvement, which Sylvia covered in the first webinar, will be kind of brought into the wider agenda that the Five Nations group I mentioned is taking forward, and will be kind of covered in the if you like, the details behind the sort of system-wide statement of intent. That will be very high level, but underneath that, we want to get best practice for public involvement, which includes the UK standards for public involvement and other related standards and principles, which include, you know, reward and recognition for what people do when they get involved in research is absolutely critical, and must be part of it as we move forward.
Thanks, Jim. And I think, I mean, many people will be aware of the RDS's fund, the Public Involvement Fund across the nation. And I think the RDS's did attempt, you know, try to do a fast track process as well, and then currently still doing it for COVID studies. So great. Rashmi Kumar has asked a good question about sort of the change to virtual and digital platforms. Rashmi, I don't know if you would like to ask this yourself. I can't see on the screen. There's so many people on, but I'm happy to read it out.
There we go.
Hi, Rashmi. Great.
Hi, Duncan. Thanks, Duncan and Jim. I think the presentation was excellent, and a good recognition about sort of the drop. I saw the curve in the presentation where the PPI involvement fell in the early days of COVID. I've been in the VCS organization for the past 20 plus years, and we experienced that in the community quite extensively. My concern, and it was interesting to note from the data that you've done and findings, that the PPI has sort of to pre-pandemic level. My concerns are about the type of public involvement. It's you know, you can always have some element of public involvement. It is the type of public involvement, and what I have seen from my own organizations and some of the research work that I've been involved in is the type of PPIs we get. We've lost those experienced patients and carers who were very actively and positively contributing into research in the past. A lot of them have had to take up more responsibilities of doing the care and looking after their own health and well-being, and therefore have not had the time to get involved in it. So although your study statistically seems to show that the PPI has gone up, my concern is the type of PPI, because we have lost so many, and I'm hearing every day from various professional organizations, they are finding it very challenging to engage with the public. So is there any way that your findings will be able to digest a little bit more if you found are available out there in the community today?
A really good question. And the point I tried to make earlier on is that the involvement that's reported in that graph is a kind of self-reported statement from applicants, and it's driven by a very poor question which doesn't really get to the heart of the difference and how public involvement helps. And it's a very mixed bag. There'll be some rather tokenistic one-off, do you think this is all right, questions through to full co-production, effective co-production and everything else in between in there. So you have to take the figures with a little bit of pinch of salt. The point you made about different types of involvement is again absolutely critical, and the support to help people get involved has been recognised within the Recovery, Resilience and Growth agenda, and getting more diverse and inclusive involvement is a really key focus on that. We're actually in the process to support that program of work of recruiting another person to our team who will have a large amount of responsibility there to work with partners across the research system to try to do as much as we can to get more people involved, more diverse people involved, as much as we can. And you're right that people are faced with all sorts of, the networks I'm part of, it's brought people in who wouldn't have previously got involved, but other people, as you say, have been taken away because they've had, the immediacy of COVID to deal with themselves. We're aware of that. One interesting thing, which I don't think anybody had a proper handle on before we set up the matching service, was how many people in the UK get involved in health and social care research. I think various have had a kind of, finger in the air idea, but 56 groups and networks on matching service, which might be, I don't know, maybe a quarter, maybe a third of all of those out there, have 8,000 members in them. So actually there are more people, again, who are involved in research in terms of being a member of a group or network, at least, than I think any of us realised. So that's a kind of, the sort of swing and roundabout to your point, that whilst some people are being taken away, actually there are a lot more people involved than I ever realised, which is a very positive thing, but it doesn't mean it solves everything. It's still a tiny proportion of the million or so people who've taken part in research are getting involved in it, and we need to do more to support and encourage more people to use their voice, use their experiential knowledge to help make research even better.
Thanks, Jim. I don't know if Lucy W, you appear on the chat as. Lucy's asked a good question about commercial companies. Lucy, to ask your question, over to you.
Yeah, thank you. Hi, Jim. Thanks for that. It was really good to hear an update about the matching service. And I think, just like I said on the chat, we were really glad that some of our PPI groups sort of got involved in that. It was just a quick question, really, just about some of the commercial companies that, we've had a couple of experiences of kind of working with them, and it's really to potentially have more of a commitment to now involving the public in their research. But I just wonder whether you were sort of aware of any, I suppose, more training that they might be undergoing, or any more sort of understanding about the value of actually involving the public, because I think there was very much kind of oh great, we've got this PPI group who are available. We've got 48 hours. Can you get some feedback to us? But there wasn't always kind of an understanding about what the sort of feedback was that they maybe wanted. So I just wondered whether you'd sort of had any conversations with any of them about how they'd be carrying that forward in the future.
So yeah, thank you for that, and thank you for your help with the service. You're absolutely right, and you've probably experienced some of the worst of it, in a sense of people thinking, oh great, here you can do it for us, when that wasn't the point at all. Overall, very, very strong backing from the Association of British Pharmaceutical Industry, ABPI, to support what we've done. And there's a global initiative called Patient Focused Medicines Development, which is a partnership between pharmaceutical companies and research organisations and patient organisations, which is sole goal is to involve patients in the entire medicines development process. It doesn't cover the whole of the industry anywhere near yet, but it's being run on a sort of sharing best practice model. So companies who buy into this and are doing some really good stuff, but within the people at the moment, in the early days, there might be one global public involvement lead for a company of 30,000 employees, and reaching all of their colleagues is going to be very challenging. But now some of the companies are really growing their teams and are doing some really innovative stuff. So the commercial sector is behind the public and the voluntary sector by quite a long way, but they are catching up. And the thing that encourages me is that in industry, if they decide they want to do something and they're persuaded it's a good thing to do, they tend to throw a lot of money at it and work really hard and catch up very quickly. So, looking on the bright side, I think we will see a lot. We will see a lot of improvement, and we'll do whatever we can in the UK to support and encourage as many companies who are running studies in the UK to do this a lot better. Through the service, Lucy, you and I and others saw those who'd never come across it before, which is why they were, they took the approach they took. We've seen a few who've come through who do really get it, and were very, very different to that. So, it's probably we're seeing greater extremes in understanding what's involved and how to do it in industry than we are in other sectors.
Oh, no, thanks, Jim. That's probably the one benefit they have, isn't it? Is having funding available to actually be able to carry out good and meaningful public involvement. So no, that's good to hear. Thank you.
Thanks, Lucy. We've probably got time for a couple more questions. I don't know if Len, who is on his phone, if you have a question about more strategic decision making. I see I can see you up here. Please ask your.
Thank you. So I just wondered, because I appreciate it's amazing the amount of work that you've all done. Like you said, it's been collaborative and it's involved a lot of goodwill, and you mainly coordinating it and in public involvement myself. A lot of the work we do is on that kind of that way. I'm just wondering if moving forward, like you mentioned, there needs to be discussions around ways that we move forward. Are there opportunities for public service users and carers to actually involved at these higher level discussions at all? Thank you.
Yeah, good question. I mean, the intention is wherever possible, we need to practice what we preach. So there will be patients, carers, service users, members of the public as appropriate involved in all of this where we possibly can and where it's going to be helpful. So there are public contributors on the Five Nations group that I mentioned, which is going to have quite an important role moving forward, and that mirrors what was done with the UK Standards Partnership. So the intention is absolutely all the way through the process is to have people involved. Because it's the right thing to do anyway, and it would look a bit wrong not to. Understandably, I would think I would hope you'd say that there won't be as many people involved at a kind of strategic level as there are at the operational level, but there will be people involved.
Thanks very much.
Thank you. Thanks, Jim. I've just got one question myself, if I may, about I think you've referred to this again, other than being in your slides, about the 22, I think it was, 22 research teams new to PPI during this process were highlighted. Did that surprise you? And what do you think that says about the opportunities for PPI?
The numbers came through, I had absolutely no idea once we set it up whether anybody would come through and ask us for the service. It seemed a reasonable number, that they were people who were not involved the public mostly. It wasn't entirely so, but they were mostly that hadn't. Actually wasn't surprising, because what we did, or what my colleagues in the approvals team did, was actually, nudge or prompt those who had involved the public before and had people who could help them to go and get those people to help them. So we had quite a lot of inquiries, for instance, from University College London. You've got a big team supporting them. So we just said, go and talk to your colleagues at University College London, because they're there to help you. And they went, oh yeah, of course, yes, and off they went. So the people we actually helped, it wasn't that much of a surprise that they were mostly new to involvement. In a sense, I wouldn't have expected less. And we were very, repeat again, that this was to complement existing services. So where they could access something else that was existing, they should do. And we mustn't overlap with existing services moving forward. And it may be that a combination of the research design services in England and other sorts of support that's available in Wales, Scotland, Northern Ireland might do the trick moving forward. It probably should, and then probably needs to be a lot better information and communication about all of the great people who are out there, many of you on this call, who do support public involvement, and getting researchers who are not aware of you aware of you. I mean, there's a lovely quote in the report of a researcher finding out that, or a public involvement professional saying that actually they ended up being put in touch through the service with somebody who was down the corridor from them, who didn't know they were there in the first place, which is, it's almost a parody, isn't it? But should I put my slides back up with the contact details? I'm just finishing off.
Great, thanks, Jim. Yes, so we have just gone over the clock, so we are due to finish. Thanks ever so much again to Jim and to Lenny, who couldn't be with us today, but thanks for the update. And just to highlight that the next CPE webinar is on the 25th of May. I've just put a note. Follow up to the PPIE payments webinar we had a couple of weeks ago. So it will be with Sylvia Bortoli, and it's a Q&A, it's questions and answers dedicated purely on the PPI guidance document that she launched the other week. So if you're not on our mailing list, I assume you all are because you're here today, you should receive notification of it, but just drop one of us a line if you fear you might miss out. Thanks ever so much for attending today, and hopefully see you soon. Thank you.